Okay, so for those of you I just admitted, we are filling out the pre-assessment via the QR code on the screen. I also put the link to the pre-assessment in the chat. So we're going to take about 2 more minutes and then we'll get started. Thank you. All right, I have 204. So Nicholas, is it okay if I go ahead and start? I'm going to take that as a yes. Okay. Good afternoon, everyone. My name is Dr. Joy Goins-Fernandez. I am a clinical assistant professor at the University of Iowa Stead Family Children's Hospital, and I also serve as vice chair for diversity, equity, and inclusion for the Department of Pediatrics. And I am an academic writing fellow for VN-GAP. Today, we are going to present a module that my med student created. So back in 2020, after America experienced its racial reawakening and everything came out, all the health disparities came out amongst COVID, I decided I wanted to do something to help reduce racial healthcare disparities. So I decided to come up with a curriculum for medical students at the Carver College of Medicine, and it's composed of 5 modules. So Vijay requested to be on my research team, and of course I said yes, and he put together the module you see here today on race-based clinical algorithms. He's done a brilliant job, so I'm going to let Vijay take it away.
All right, thank you so much, Joy, for that wonderful introduction, and thank you, VN-GAP, for allowing us to present this presentation for you today. This is kind of an interactive presentation, so we'd love all of you to interact with the presentation and put things in the chat when I ask you to about the case and whatnot. So we're all learning together. So we're presenting today on eGFR and using this as a case study on how we look at Black people and different races in medicine, and how we've kind of cemented different ideas we have about people in the fabric of our understanding of medicine. So let's get started with, I have no disclosures. Let's get started with a patient case first. So this is a 52-year-old Black woman who came in to the ER with a chief complaint of a shortness of breath and severe neck pain. She tested positive for COVID-19 later on, and she was admitted to the hospital with increasing oxygen demands. At the time, she requested remdesivir, which is an antiviral medication, but she was told by doctors that she didn't qualify. Now, her neck pain was getting so bad that it was very uncontrolled. She requested pain medication over and over, but was repeatedly denied. Due to the increasing O2 requirements, a CT chest was finally ordered, which showed pulmonary infiltrates. And hours afterwards, hours after the imaging was done, opioids were finally given to the patient. She later in the hospital, of course, weaned off of her O2 and was discharged a week later. But however, 12 hours after discharge, she spiked another fever, this time at 103, and she was exhibiting early signs of sepsis, as you can see there with her vital signs, tachycardia and hypotension. She was rushed to the ER where she tested, again, positive for COVID-19 and bacterial pneumonia. She was intubated shortly afterwards. She couldn't protect her own airway and required increasing O2 demands. And unfortunately, 2 days later, she went into cardiac arrest and passed away. So this patient case, this woman was a woman by the name of Susan G. Moore. She was a Black American woman, and she was actually a physician practicing geriatric medicine in Michigan, Grand Rapids. And what was special about this case is that, she knew all the medicine, that was going on. She knew physiology, but she actually recorded every day on Facebook Live. So everyone would tune in every day for her daily updates on what was going on. And she was very vocal about her care because she knew that anyone else, who was put in that position, who didn't have medical knowledge, may not be able to fend for themselves. So I posed the question, to you all in the audience, what does kind of her story illustrate to you? And please feel free to, throw things in the chat if you think of anything. And I think Dr. Goins-Fernandez is going to monitor the chat too.
Feel free to unmute. There's so few of us here. I think it's okay if you unmuted yourself and just responded as well.
Definitely.
I feel like this is just blatant ism here. This is just I forgot what it's called, implicit bias at play. It's a very clear example.
Yeah, great thought. Implicit bias, could you just expand on that a little bit more? What do you mean by the implicit bias here?
I mean, it's the idea that we teach it. I also facilitate a cultural humility session at my school, and something that we teach, like, to be aware of your implicit bias is the things that you assume of others right when you see them, because everyone's dressed in the hospital gown, everyone's in that room. So to you, they're just another patient that you present, but you don't know anything else except for the chief complaint and the handoff. And I feel like this kind of case makes me really mad, because it's almost as if like everything you work towards just gets invalidated immediately.
Absolutely.
So you don't get any like gratification for what you worked for.
Yeah. Thank you for the insight there. Absolutely. Her increasing pain requirements, why wasn't she given her pain medicine? Pain is subjective sense, so we don't have an objective measure of that. Why wasn't she given this pain medicine? Second question I posed to you all, do you think her race played into her a factor in her medical care? And if not, why do you think so? And Lorraine, it's totally fine if you want to speak again. This is a nice discussion we're having.
There's something in the chat. Says the considerations also indicate certain assumptions on race and medicine.
Yeah. Who could someone expand on that? Whoever said that.
Oh, sorry. I'm not the person who said that, but I would like to expand on it.
Yeah.
So I completely agree. And I think that her race definitely played a factor, because I feel like there's this notion that African-American patients, they can take on more pain. And because of that, they were probably less likely to give her medications. Or there's also the notion that a lot of African-Americans are on drugs, or they just want free drugs. So they probably didn't want to give her an opioid because, it's a strong medicine and it will cause it can lead to addiction.
Yeah, that's good insight. And we frequently see this with, sickle cell, for example. We see that in many Black populations. These patients repeatedly come to the ER because they're having painful vaso-occlusive crises, and they're not getting the pain medication that they so desperately need. She had to actually. Dr. Moore had to ask for a CT, and only after a CT showed something was wrong with her, they actually gave the pain medicine. And that's not how we practice medicine, right? If a patient's in pain, we typically like to treat that pain before they have to prove anything to us. So good insight there, definitely. So this case kind of illustrated to a lot of people early on, this happened in 2020 when Dr. Goins-Fernandez said, when, we started thinking about race and medicine. How are Black people looked at in medicine? And there are several, big celebrities that came out and talked about this. And here's just a few examples. Serena Williams, who experienced a pulmonary embolism right after her pregnancy, but was not believed that she was having a pulmonary embolism, and she actually almost died. Kamala Harris and Beyonce, Allison Felix, all talking about their issues with pregnancy and how Black people have a 3 times higher mortality than white women, but that statistic isn't even being researched as rigorously as other important medical questions out there. And celebrities like Kareem Abdul-Jabbar and Bernie Mac also speaking out, about Black people in medicine. So thanks everyone for engaging in that conversation. And, because if this was a face-to-face, I'd ask you all to put your heads down and raise your hand about what you think about this question. But I'll just pose it and I'll ask you to think about it throughout this entire presentation because we'll be answering this question. So do you think clinicians integrate race in their clinical decision-making? Whether this be implicit bias, no matter how you think, do you think they do? And with that, I will keep moving forward. Here's our 3 learning objectives, 3 things I want you to take away from this presentation after you leave, to discuss ways that race is considered in clinical algorithms with emphasis on this particular equation known as the eGFR equation, and we'll get into what that is, identifying differences between race and ancestry, and describing the implications of removing the race correction factor from the eGFR equation. So we're going to go through another patient case to kind of illustrate eGFR. So this is case number 2. This is AT. She's a 43-year-old Black woman with an 8-year history of uncontrolled type 2 diabetes, hypertension, coming in with a complaint of left foot pain. And here's her past medical history. We're seeing quite a bit in the past medical history: type 2 diabetes, neuropathy, CKD, chronic kidney disease, due to the diabetic nephropathy, hypertension, and all the other things. Really, all of these are pointing towards a metabolic syndrome type picture. She has OSA and all these sequelae of these chronic diseases. And here's her medications. So she's on quite a bit for, hypertension, for diabetes. She's on metformin, neuropathy, gabapentin, for her thyroid conditions. And she's also on a course of antibiotics for probably some kind of infection. So here's her family history. Both her parents are deceased. Mom had a heart attack at 65, father stroke at 43. Brother and sister both have type 2 diabetes. Sister has chronic back pain and she is taking opioids for that. And here's her social history. She's married, 4 sons, and their ages are listed there. She has limited exercise and she works a desk job for 40 hours a week. And she's been out of her medications over the past week. Here's her review of systems. She's positive for severe left foot pain, nausea, itching, claudication, which is pain in the legs with increased effort, snoring, fatigue, and dysgeusia, so like a weird taste in her mouth. Here's her physical exam. She's really, it's positive for, speaking in short sentences. She's kind of in a little bit of distress. She's got dermatitis over both of her legs and a foot ulcer over her left plantar metatarsal draining fluid. She's having trouble breathing with bibasilar crackles. She has a murmur, a hollow systolic murmur with 2+ pitting edema. So, you press down in her pretibial area and we see that kind of pitting. And she has decreased sensation over both her extremities up to the shins, probably from the neuropathy. We ordered some labs, we got a BNP, and you notice that a lot of them are whack, right? They're all off here. Her potassium is increased, BUN is increased, creatinine. So these are values we measure that typically indicate kidney function. Creatinine is at 3.0, glucose is elevated, suggesting her diabetes is probably not under control. She has some sort of infection with her white blood cell count elevated. Lipids are elevated and endocrine seems like it's elevated. She hasn't had medication to control these. So a lot of these labs are off. So with that being said, if we're going to sum this patient problems down into, 5 problems we need to fix, you go into a patient room. If there's 1 or 2 or 3 things we want to fix with this patient, what are they? And I pose this question to everyone in the audience. If you have a patient coming in with left foot pain, what are our patient's problems that we want to fix?
Left foot pain first thing with claudication, clots,
Mhm.
thromboses.
Yes, definitely. Yeah, with chronic kidney disease, these patients are typically, hyperthrombotic. So yes, so pain, number one, pain, good. Anything else? And this could be anything with the patient, social history wise, anything. And there's no wrong answers. Take one more. Lorraine, you want to shout us out on another problem?
So there's something wrong with my Zoom and I can't see a
Oh,
slide.
sure.
It's not just this this presentation that's been happening through all my everything else. So yeah.
Is it hypertension?
Yeah. So, I mean, other problems like the chronic conditions you're suffering from, hypertension, diabetes. So that also comes, it also begs the question, why has she been out of medication? Is there another reason why she's not taking her medications for these conditions? Has that been explored at all? These are all important questions. So number one problem we should be focusing on first, foot pain. Why is she in pain? She has an ulcer, right? Something maybe related to that. Second, worsening kidney function. We saw both her BUN and creatinine were elevated, and she has stage 4 chronic kidney disease. She's already been diagnosed. What are we going to do, moving forward? Does she need specialist treatment? Would she be eligible for transplant if that's available? And things like that, like Dr. Goins-Fernandez was saying, her chronic conditions, are they not being controlled? Complex social situation of a lot of kids at home, a lot of trouble finding time to exercise and eat healthy and all of that. So very good. So again, I ask that you all try to interact, because this is the really interactive portion, and it's less me talking at you. In this next one, what medications are available to us for treating this patient's pain? And again, there's no wrong answers.
I mean, if you're going up the pain ladder, I think it's NSAIDs first.
Mhm.
NSAIDs. No,
Yeah.
Tylenol, NSAIDs.
Yeah.
And then I'm gonna jump to opioids because I don't remember. the
Yeah.
last-
No, that was great. Yes, absolutely. Good work. So NSAIDs, ibuprofen, naproxen, opioids, like Lorraine was saying. She has neuropathic pain, so gabapentin might be a good option for her. NSAIDs might not be the best option for her just because she has a level of chronic kidney disease, and NSAIDs already wreck the kidneys, so may not be the best options for her, but certainly something that's on the table. So given what we know of her racial and social background, how do you think we should manage her pain? And Lorraine, because you answered the question on pain medication, I will pose this question to you. Or does it have
I
an
know for
impact?
gabapentin, you have to look for the creatinine clearance. I don't remember the exact numbers, but if you do that, I think gabapentin is pretty effective. As for NSAIDs, I mean, for kidneys are screwed, I guess no NSAIDs, but also I don't think she has any gastric issues.
Mhm.
So and
Yeah,
opioids, I don't know how to titrate opioids.
yeah, no, that's good. Does the fact that her sister is on opioid medications for her chronic back pain, does that impact your decision to give her opioids at all?
Not really. I feel like I would treat the patients separately. Like just
Yeah.
I mean, I guess there is the idea that she might give opioids to her sisters, but I mean,
Mhm.
that's not my first instinct.
Right. So that like leads into the assumptions, right? Absolutely. Opioids are definitely indicated here for her pain, and it's something that's again on the table for treating it. And I pose this next question to all of you, not just Lorraine, based on our social situation. So, having a lot of hours to work and not having enough time. What supports do you think she feels? Do you feel that she needs to return for follow-up? So in the future, let's say we treated her, condition now, probably a neuropathic, foot ulcer or diabetic foot ulcer. Let's say we treated that. Moving forward, how should we ensure that she's going to follow up with us?
Well, I think there should be some appropriate support for her to be able to come into the space, transportation, all of that stuff, and to follow up with some of the changes that she needs.
Absolutely. Yes. Thank you. Transportation. We know a lot of times we forget that patients don't just teleport to the clinic, right? They have to get there somehow. Is transportation an issue for her? We previously said why she wasn't, we should probe why she wasn't taking her medications. Was this a reason because she felt, were there side effects that we didn't know about? Did she feel like she didn't need them? Were people not explaining this to her? There's a lot of issues that just haven't been probed with the patient, right? Anyone else have any other ideas?
I was thinking childcare. She has 4 kids.
Yeah, absolutely. We need time to go and go to the doctor and get evaluated and have all the labs done, right? How does childcare look for her? So it sounds like, I know a lot of people have alluded to this, sounds like we should probably involve another, job here, a social worker, probably, right? Social worker could help with a lot of these things, like transportation, like childcare, things like that. Someone to coordinate her care. So a lot of these things you alluded to. Another thing that, these are just things I was thinking about, like mental health things. Were those ever probed with her? Sounds like she has a lot on her plate right now. 4 kids, going to work, rigorous job hours. Is there an element of anxiety and depression that we haven't screened for? Has she been screened for that? Are there other insurance issues that, we haven't addressed? Is that why she's not getting her pain meds? So things like that. Great work. Now, moving on, I've talked about this a little bit, but now we're going to switch gears and focus on her kidney function, because that's at the crux of this whole patient case. Her kidneys are doing bad, right? They are essentially close to failing here because she's in, stage 4. So we're going to kind of address how we assess kidney function and how we measure kidney function. So we assess this with a calculation that's called eGFR. This stands for estimated glomerular filtration rate. And like it says, it's estimated, right? It's a calculation that kind of estimates how we measure our kidneys, so kidney function. So we have certain agents that our muscles and our body release, and you can see those agents there: creatinine and cystatin C. So creatinine is a molecule that our muscles break down, and that's what is measured in these assays and these levels here. So as you can see on the figure on the right here, that's my arrows pointing. There is a relationship between creatinine and GFR. So the idea is the kidneys filter the creatinine. So if the kidneys aren't doing so well, the creatinine levels increase in the blood. So ergo, there's a inverse relationship between creatinine and GFR. And as you can see, there is a very narrow range between, sorry, this line here is supposed to be down here. This is normal. Normal level is around 0.8 to 1.1, okay? So if you imagine a line here, you can see that it's not very accurate. Creatinine itself is not very accurate at the ends of this spectrum, because it's kind of it's not a linear relationship. It's more of a, exponential relationship. So at the low end and the high end, it's very inaccurate. But if we're hitting it at the sweet spot, it's kind of it's not actually a bad test. However, there are several factors that play into measuring GFR, not just creatinine. There's things like age and sex and other things that impact our kidney function. And these kind of moderator variables have been plugged into this formula that was created by this group called the MDRD group. And here's the acronym here. The MDRD group, and moving forward, the CKD-EPI group, which is just the same group, but later on. So this is actually pretty important, right? Now we have a great, or it's not a great test, but we have some way of assessing kidney function. Like we have spirometry for lung function. We finally can measure kidney function in just an outpatient clinic visit. And this isn't something willy-nilly. This is a big deal because now there's a lot at stake on this one value, and there's a lot at stake that clinicians have placed. So like you can see there, kidney transplant referral, a lot of centers use this as a benchmark to refer to a kidney transplant center. We, like some of you were saying, dose medications based on this one value, because if your kidneys aren't doing the best, you don't want to use certain medications because they may be nephrotoxic. So there's just some important limitations we have to keep in mind when we use this equation, as they can be unreliable in a lot of different populations. So those at the extremes of body weight, because we said creatinine is a byproduct of muscle breakdown, those at the extremes of body size and muscle mass may not be the best to use this equation on. So bodybuilders who take creatinine or creatine frequently might have artificially elevated creatinine clearance. Patients with unstable creatinine concentrations, so those who are acutely ill, measuring creatinine might not be the most accurate in those patients. So med students, if there are any, your attendings will yell at you if you trend creatinines in the hospital, because they're not as accurate. So I went through and I went to, this is just a freely available calculator for you to use on the internet. I went and plugged in all the variables that we have for our patient, AT. So she is a female, 43-year-old female, and here's her creatinine. She's Black, and we pop out a number. She's 21. And what does that mean? So 21 is kind of sitting here at stage 4, right? Trending at the lower end of stage 4. And transplant eligible for several centers is when you dip down below 20%. So just based on looking at these values and not thinking about patient's social history or anything like that, she would not be considered eligible for a kidney transplant, even if she wanted, or even if the clinicians thought she'd be amenable to this. So I'm just going to go over how the GFR equations were created, just a brief timeline, and we'll keep moving here. So really, there was a couple studies, and I'm just highlighting one of those studies that suggested there was at baseline a difference in anthropometric definitions between Black people and white people, kind of making this a biological fact that Black bodies and white bodies are fundamentally different. And there's a study, we can see Harsha published, that Black kids had less body fat, and they in fact had higher muscle mass than their white counterparts. And this paper by Levy, which was the MDRD paper, the paper that put forth the first eGFR equation, they didn't cite this exact paper, but they were kind of running off of that fact. If you were to look at the papers that were cited by Levy et al., there really wasn't any basis behind why, they said Black people had higher muscle mass, except for these kind of aggregate studies of measuring a lot of Black people and white people and comparing them. So this was just breaking this paper down just a little bit. They included 1,628 patients with chronic kidney disease. And what they did was they found a gold standard for measuring kidney function. And this is the best possible way you can measure kidney function. You inject a particular iodine substance in the blood, and you measure how much leaves the body via urine. So you know how much is going in, you know how much is going out. So that's the gold standard. Now, they did that, and then they measured their serum creatinine as well. And what they did was they trended that. So it is essentially a regression with the patient's creatinine and eGFR, and trying to match up what other variables can we also put into this equation that make this association between eGFR and serum creatinine more close to the gold standard. So it's trying to fit the gold standard, essentially. And they did that. They identified several factors. Age was a big factor, right? As you get older, your kidneys aren't going to function as well. Female sex, non-Black ethnicity, higher urea. They found, if you can see on this on the right here, there's two figures. At the same GFR level, so let's just say 20, At the same eGFR level, we're seeing that white men have a lower creatinine level than Black men, right? Can we all see that? So they had to account for this in some way. So what they did was they had a race correction factor, said Black people have more muscle mass, we need to correct for that, right? So they had a race correction factor that they applied. And this made eGFR 18% higher for Black patients because they wanted to account for this so that both are at the same line, essentially. So they fit the overall model for this. And this was a big problem because it was not a representative sample, and 80% of the population is white and only 12% were Black. Furthermore, who they defined as Black was not at all kind of illustrated in their population. It was just not very transparent in their methods. And also, this was all this chronic kidney disease population. So can we use this for healthy people? I don't know, but that's what we've done in clinical practice. We've started to use this for everybody. So then
Vijay, do you want to take a question now?
Sure, yeah, we can.
Carolina asks, have any of these papers been retracted?
These papers have not been retracted. They are still in the literature out there for you to read. Even though it's not sound science, they're still out there for you to read. Good question. So moving forward, and in fact, this was in 1999. People really didn't think about this until 2008, when Su et al. Showed that the higher serum creatinine was higher in Black populations versus non-Black populations, even after adjusting for muscle mass. Now, this is kind of a weird coincidence, right? It's just kind of weird to think about. If we said that Black people have higher muscle mass, but they still, if you account for that, they still have higher serum creatinine, well, maybe something else is impacting their serum creatinine, right? Maybe it's not muscle mass, maybe it's some other factor that we're not adjusting for in our model, right? So the MDRD equation in sum turned out to be pretty inaccurate, and especially really inaccurate when you're at the ends of that graph that we were showing. So at higher eGFR and lower eGFR. So we need a new equation, and that's where the CKD epi equation came from. So it was the same authors that came up with this. So I'm going to use the same equation for AT here. So this was the old equation, the MDRD. This is the new equation. And this is just kind of comparing the two. If we were to use the same values, so she's a 43-year-old Black woman, right? She's getting a value of 21 with the CKD epi equation. Put in the same values, and it pops out as 18 for a non-Black patient. So if you can see a problem with this, what did we say? 20, a value of 20 was threshold for kidney transplant referral. Well, just looking at this at face value, the non-Black patient would be referred and the Black patient wouldn't. Now, of course, there are several transplant centers have different criteria for this, but it's been studied that just in fact using this equation has made several people ineligible for kidney transplants out there. So moving forward, just constructing a timeline for how things have moved from then 2008 to now. So this was when the new equation came from, CKD epi, and in 2012 we added a new kind of parameter. So we had creatinine, and now we're adding cystatin C, and that they found wasn't impacted by diet, exercise, muscle mass, anything like that. So it made the equation better, but it still had that race correction factor. And then what happened was 2020 hit, and 2020 was crazy, like Dr. Goins-Fernandez was saying. George Floyd happened, and the Black Lives Matter movement gained momentum, and people were starting to question a lot of things that we do, even in medicine. Maybe it may not be as sound as we once thought. And for the first time, medical students were actually calling for a change. And this is when we found out the importance of multiple members of the team. Medical students had time to sit down and think about these complex issues in their didactic curriculum. When we mention race, why are we mentioning race? And in 2021, because of the fact that medical students were calling for a change, several meetings were put forward and people were talking about the data. And University of Washington, a big health center, in fact, dropped that race correction factor. And in 2021, finally, the National Kidney Foundation ended up dropping the factor overall. So you can see from 1999 to 2021 how things have changed and fluxed, and how even social factors have kind of played into medicine, and how we have to advocate for our patients, and medical students did exactly that. So this is where kind of gets at that third learning issue, understanding the difference between race and ancestry. And that's really, really important distinction to make, especially when we're teaching future medical students about the diseases. Okay, so race does not equal ancestry. It's not, they're not synonymous terms. So race is a homogenizing and socially constructed concept based on superficial features like skin color. It's not a rigorous concept, even though it's been applied in medical literature quite frequently. It's not a rigorous concept that has biological meaning. So it's previously been used to deny freedom and goods for people for centuries in the US, slavery, everything that Black people have gone through, and not even just Black people, just any person of color, right? So ancestry, on the other hand, is a genetic inheritance of individuals. This is more of a biological term. And note that there might be relationships between race and ancestry. So, for example, we talk about sickle cell, how frequently that's associated with Black people, but in fact, has a relation with malaria, right? And malaria, a lot of areas where malaria is prominent is in Africa. So conflating the two can lead to those stereotypes. So genetic ancestry kind of admits the complexities that come with biology, right? Race doesn't do that. It's very homogenizing, and it allows people to take things at face value and say, stereotype them, essentially. So many people have flipped this and said, well, maybe we should use race as a risk factor that determines and predicts disease because of a genetic susceptibility. Because if we can use race as a risk marker, maybe we can address those changes. Maybe there was a social determinant that wasn't addressed in the early MDRD equations because we're using race for that and not ancestry in any way. So because of using race in the way we did, we might have missed bias, systemic disadvantage, vulnerability that could have been included in those original equations. So these are just some questions I have for you to ponder and not answer out loud. If you've ever been asked what race you are, just think about what race would you identify as? And if you're mixed race, how many questionnaires, and I'm primarily talking about healthcare questionnaires, allowed you to choose multiple races? So there are several implications of dropping the race correction factor, and a common counterpoint to taking that out, as if you drop a lot of these people down to a lower eGFR, then it's going to make millions more people have a kidney disease diagnosis. Right now, all these people are being afflicted by disease. And we've seen this with other diseases like hypertension, right? We're lowering the threshold down to used to be 140/90, now it's 130/80, and now it's 120/80. And below that's pre-hypertension. So dropping this down is going to have so many more people impacted by this. So we need to find a sweet spot between underdiagnosing and overdiagnosing. And this is the Goldilocks effect, right? There are several pros. A pro is removing race will increase the prevalence of CKD and reclassify a lot of patients, as you can see, 29.1% of patients, to a more severe stage of CKD. Medicare would cover disease education and nutrition therapy because now the prevalence of this disease has increased. And 0.05% more people would qualify for kidney transplants. Now, that doesn't seem like a lot, but that's a significant impact on the quality of life of several people in the country. And that's a significant burden off of our healthcare system as well. People who don't have to go to dialysis every 2 days, right? Here are some cons. 2.1% of people would be disqualified from donating their kidneys because now their eGFR is a little too low. Cystatin C might not be covered by some insurances, so it could lead to cost hikes for just a routine lab measurement that you could go in a family practice and just order. And the VA system does not currently use cystatin C as a lab standard, so that would be a send-out lab for a routine measurement. So I pose the question to you all. Would you consider any of these pros as cons or cons as pros? And if not, that's totally fine. But I want to hear your thoughts.
Are you able to scroll to the left a little bit? Or
Scroll to the left.
maybe it's my screen then, yeah. I can.
Sorry, Lori. Any ideas?
Sorry, I can't see the pros. I'm wondering if there's.
Okay. Dr. Goins-Fernandez, can you see the pros? Is it maybe it's my screen?
Yeah, I can see them. So the
Oh, then it's me.
that's
Okay.
right. The pros were removing race may increase the prevalence of CKD among Black adults from 14.9% to 18.4% and may reclassify 29% of Black patients to a more severe stage. Another pro with Medicare would cover disease education and nutrition therapy for higher percentages of people, and then 0.5% more people would qualify for kidney transplants. So can any of these be cons as well?
Any ideas? So a lot of people would say removing race, and increasing prevalence of CKD is, in fact, if we increase the prevalence of a disease of people who, generally we associate, and this is me stereotyping, right? Especially in Iowa, where we have several Black adults who are already doing poor, like socially, right? Who cannot access healthcare. And if we're increasing the prevalence of a disease like this, is that a good thing, right? People who are accessing healthcare. So a lot of people would say that's maybe a con. Now, looking at the flip side of that, we're not, if we take out this, kidney factor equation, whatever, now everyone's at the same playing field, right? We're not disadvantaging one over the other. We're not making assumptions based off flawed science. And we can get these people help now because we've taken out these barriers. One barrier was just, I guess, in using this equation, being Black, honestly, because this was a quantifiable thing that we use to measure kidney function. Just by being Black and walking into a family medicine practice or whatever, you were disadvantaged because this equation was used. So kind of back to this case.
So there was go ahead.
Yeah.
Oh, I just wanted to kind of mention one thing that is kind of related, and that is the colorectal cancer screening age change that actually took place as as something of a protocol, because of this understanding. Obviously, it has the same kind of questions. Does that then like increase the weight that the system has to in the number of people that you are screening, the efforts that need to go into it to screen more people, but that kind of reminded me of that in the same that is the same consideration here.
Yeah, absolutely. Thank you. So yeah, now, like you said, they changed the colon cancer screening from 50, what is it, to 40 or 45? I'm not sure. So yeah, now we've decreased that threshold for screenings. Now we're maybe catching more people with colon cancer, right? And it's kind of the same principle, like you were saying. So back to the case, if we remember AT still, we are plugging in the same values here. So again, using the CKD 2009 equation, same values, 21, and this is her not being Black, 18. And now we're going to use the new equation, the 2021 updated equation. And if we plug in everything, we pop out a new value, and it's 19. So now, just again, looking at this, not being based on race, taking this at face value, she would be offered a kidney transplant just by looking at this. And note that that puts everyone at the same playing field. There are discussions that show that it might be inaccurate for those not Black and white, or sorry, non-Black and Black, but now it's inaccurate for everyone. One group isn't being systemically disadvantaged because of that. So how have other institutions handled this dilemma? The NKF, or National Kidney Foundation, and as you can see, the American Society of Nephrology came up with the final report, and that was the 2021 report that I was talking about on the timeline. And they came out with 3 important recommendations. They recommended implementing the CKD epi equation without the race correction factor in all US laboratories. So even if cystatin C is a send-out lab, at baseline, you can take out the correction factor, and that could help a lot of this systemic disadvantage we're putting patients in. They recommended efforts to increase use of cystatin C. So of course, using cystatin C would make this whole equation more accurate. And third, and the most important here, is funding research, more research on GFR estimation to discover novel markers of kidney function. I don't believe we have found one yet. And creatinine may not be as accurate as we once thought it was. So in line with these 3 recommendations, several healthcare systems have taken out this race correction factor. And as you can see to the right, Mount Sinai and MGH, really prominent medical centers. And my home institution, University of Iowa, has finally decided to take out their race correction factor as well, which is super exciting. So, you think this is only a problem of nephrology. And this one study, or it was more of a commentary piece, kind of looked and probed through several race-based clinical algorithms and found quite a bit. And of course, this wasn't systematic. There are several equations that aren't covered here, but this is just kind of to show you the depth of how big this problem is, how pervasive it is. You're seeing this in multiple fields of obstetrics, urology, oncology, how race has been quantified for some unknown reason, because as they did in eGFR, it had some difference in outcomes. But of course, maybe they may not be accounting for some social factors in their original analysis. And this is the problem with conflating race and ancestry, is this problem you're seeing right here, how we've quantified this. So overall takeaways that I want you to take away from this: race is a social construct and not a valid proxy for biological factors. Those equations using race correction factors need to be questioned, with special emphasis on how they might impact patient care and equity and distribution of medical care. Because we've used the eGFR equation for so long, how many patients have we disadvantaged because we've been inaccurately overestimating the eGFR of Black patients? And third, and this is what medical students do all the time, it's what I do all the time in clinic, asking questions when we're concerned about questionable clinical practice. It was easy for so many frontline clinicians to take this eGFR equation at face value and estimate GFR for just regular patient care. But it wasn't until medical students started speaking up and asking questions about why are we doing this, that change actually happened. So advocating for change. And so here are the references for this presentation. And I'd like to acknowledge, lastly, Dr. Goins-Fernandez for helping me put together this presentation and kind of leading me through this whole process. both Dr. Nicole Del Castillo and Ariel for helping put together the presentation as well, and consultation from wonderful nephrologists, Dr. Lee Sun, the Division of Nephrology, and Dr. Nora Dean in Division of Nephrology as well. So I would love to take any questions, but I also love for you guys to fill out this post questionnaire or post presentation survey as well. We always want to get better on presenting, so it would really, really help me if you could fill out this, and I'd be happy to take any questions now.
Okay. And I'm also putting that the survey link in the chat.
So not really a question, but I just a comment. I at one point worked with a professor who was into transplants, specifically kidney transplants, and she had looked into living donors versus deceased donor kidneys transplants and looking at the demographics. And what she found, at least this was only based on the US RDS from New York State, she had found that Black women had actually increased odds ratio likelihood than white women to get a living donor kidney. So I thought that was interesting. But now I wonder if like how they calculated if that had any play into whether it's just social, like, oh, they just happen to have more donors, or like a family member donated. Do you know what I mean? But,
Yeah.
sure. But that was just interesting because we had expected like the opposite.
Right.
It was just interesting to note. That's all.
Yeah, definitely. Thanks for bringing that up. So that kind of gets back at having more research on equity and distribution, because for example, like the study I was referring to was an MGH single center study. Sounds like your study was done in one state, but there hasn't, from what I've seen in the literature, been something more systemic where we've actually quantified how much, disparity there is in transplants, for example. So I think we just need more research regarding this for us to be able to identify the gap. So yeah, thanks for bringing that up.
There's a comment in the chat from Carolina. Amazing presentation. Great job, Ajay.
Thank you, Carolina.
I want to say great job as well. Very good work.
Thank you.
I just had a question. Actually, was it Lauren who mentioned the study in New York State? When was the period of that study?
Oh, that's a good question. I'm trying to pull up, it's nestled in my emails somewhere. I've been trying to find it. If I find it before the session ends, I will let you know.
Okay, because that would mean a lot, whether, like it was more recent or, like earlier.
I think it was in the 2000, let's see.
Yeah, I would love the DOI to read that paper.
Yeah, thank you.
Any other questions or comments for Jay?
Yeah. Looks like Dr. Garcia Everett's also on this chat, or on this presentation. So if Dr. Garcia Everett, if you have any insight as well, she is a nephrologist. I am a med student, so she also has insight into this. Would love to hear if there's any studies that have been out, published on this.
Sorry, I was able to jump in from your session to mine for the last few minutes. So you did it from what I saw. You did a great job.
Thank you.
Oh, so Dr. Gamita, so this is I found her PowerPoint at ATC 2020, and it says this was study included 106,000 primary adult living donor kidney transplants reported to UNOS OPTN from 1998 to 2019.
Okay.
Quite a bit of time there. Yeah.
Yeah, for sure. And I think it was like in a multivariate model, with white women as the base. Black versus white, the odds ratio was 1.38. So I guess that means it's more likely for Black women, right, than white women to receive a living kidney. But of course, we don't know like the reasons behind it and where we're farming the data from specifically.
Yeah.
Right. Definitely. All right.
Any last question or comment before we sign off?
And if there are any medical students on this call, I would urge you, if you're in the didactic curriculum or even in the clinical curriculum, every time presenter or professor mentions race, and they associate it with some disease process, whether it be increased risk of pulmonary embolism or whatever, I would encourage you to also look into that a little bit more about why that is. Is it a biological reason? Because frequently, and I'm going through this right now, we study for boards, and we associate a particular disease process with Black, for example, like G6-PDX deficiency or sickle cell or FSGS or something like that. But we don't have a biological reason for why we're saying these things. So it leads to a lot of stereotyping. So for medical students, especially, and all of you, when you see this kind of associations being made, always question it. Is it a genetic thing or like an ancestry thing, or is it a race thing? So yeah, my soapbox, I'll get off of it.
Yeah, this is a very, important conversation. We had this past couple of years, we were looking at, again, like student engagement. A student pointed out mention of race in a case, in a question, actually, where they were, in a testing environment, where the mention of the race was absolutely not necessary. Actually, it was just a pure stereotype. And then we were able to raise that question through the curriculum committee, and now we have a protocol for actually developing the questions that there has to be a specific reason why race is mentioned at all, if it is mentioned in any case question. If there isn't, then there's no reason for it to be mentioned, because it just serves as a stereotype perpetration.
Yeah, definitely.
Well, thanks, Vijay. We're at time. So if you are here for the full presentation, I encourage you to fill out that post-assessment for us. Thank you, everyone.
Thank you.
So Vijay, I'm going to the next session in the conference, but I will debrief with you later.
Sounds good. Thanks, Joy.
Sure. Bye-bye.